This will cover infectious diseases for the pediatrics board review. We'll start with congenital infections. Babies with these infections may present as small for gestational age or with IUGR. They may have rash, hepatosplenomegaly, transaminitis, thrombocytopenia, ophthalmologic findings like chorioretinitis and cataracts, and two of the congenital infections that we discussed can present with intracranial calcifications. We use the Torches mnemonic, which stands for toxoplasmosis, rubella, CMV, HSV, enterovirus, and syphilis. LCMV, parvovirus, and Zika virus are also important to consider. Toxoplasmosis is contracted from undercooked meat and cat oocysts. In immunocompetent hosts, it just causes a self-limited illness similar to mono. In immunocompromised patients, toxo can cause encephalitis, meningitis, and retinitis. In babies with congenital toxoplasmosis, they may develop chorioretinitis, hydrocephalus, and they may show diffuse intracranial calcifications with ring-enhancing lesions. Later in the course, they can have sensorineural hearing loss, vision impairment, and developmental delay. Toxoinfection is diagnosed with IgM, IgG, and PCR serologies. Pregnant women should receive spiramycin, and infants receive pyrimethamine, leucovorin, and sulfadiazine for a year. With congenital rubella infections, infants can be SGA with microcephaly and microphthalmos. They can also have hepatosplenomegaly, a blueberry muffin rash, sensorineural hearing loss, cataracts and glaucoma, PDA and pulmonary artery stenosis, and radiolucent bony abnormalities. The prognosis is worst if rubella is contracted in the first 12 weeks of gestation. Rubella is diagnosed with an IgM level in the first 6 months of infection, or the demonstration of an increasing or stable IgG elevation between 7 and 11 months of infection. A viral culture serology can also be used regardless of the time frame. CMV is the most common congenital infection. Infants can have microcephaly, chorioretinitis, sensorineural hearing loss, hepatosplenomegaly and transaminitis, thrombocytopenia, blueberry muffin rash, and periventricular calcifications. IgM can diagnose CMV or a salivary or urine culture in the first 3 weeks of life. If a newborn is symptomatic, CMV is treated with valganciclovir or ganciclovir in the first month of life for a total of 6 months. While on treatment, the white blood count and the LFTs should be monitored. This slide shows the different intracranial calcification patterns present for toxoplasmosis versus CMV. Toxo has diffuse parenchymal calcifications, and CMV has periventricular calcifications. Newborns with congenital syphilis can initially have snuffles, lymphadenopathy, pneumonia. Skin findings include a rash and peeling skin. They can also have osteochondritis, hepatosplenomegaly, thrombocytopenia, and hemolytic anemia. And patients with syphilis can have nephrotic syndrome and edema. Congenital syphilis can also be fatal with hydrops fetalis. Late congenital syphilis can present with the Hutchinson triad, which is keratitis, sensorineural hearing loss, and Hutchinson teeth. Hutchinson teeth are peg-shaped with a central notch. Late syphilis can also manifest with mulberry molars, saddle nose, perforate palate and septum, frontal bossing, and saber shins. You diagnose syphilis with a dark field examination for spirochetes or RPR testing and confirmatory FTA treponemal testing. The VDRL or RPR test can be false positive with autoimmune diseases, and the FTA test is also positive with Lyme disease. So it's important to do both tests. If CNS disease is present, then we treat syphilis with penicillin G for 10 days. It'd be reassuring if the mother was treated more than a month ago for a syphilis infection, or if the infant titer is less than the maternal titer. For cases like these that are more reassuring, you might consider deferring your penicillin treatment or just giving penicillin one time. For HSV, it's usually HSV2 when it's a congenital infection. It's usually transmitted during delivery and affects the skin, eyes, and mouth. Disseminated HSV and HSV encephalitis are associated with worse prognoses. Eye lesions include keratitis, conjunctivitis, and chorioretinitis. Mucositis, stomatitis, and gingivitis is associated with the friable and malodorous mucosa for HSV. Disseminated HSV infections typically present in the first 1 or 2 weeks of life and can resemble sepsis, but also can have hepatitis, pneumonitis, and DIC. Encephalitis from HSV presents with seizures, tremor, and irritability. The LP-CSF might show pleocytosis, but can also be normal initially, so a PCR for your CSF labs is really important. On your CT scan, temporal lobe changes are associated with HSV encephalitis, as well as PLEDs on your EEG. Those are periodic lateralizing epileptiform discharges. HSV is treated with IV acyclovir in infants. Acyclovir is given 3 times a day for 2 to 3 weeks. For central nervous system disease, the CSF PCR should be rechecked after your treatment to confirm eradication of disease, and suppressive acyclovir is continued at a lower dose for 6 months. While on acyclovir, a CBC should be monitored for bone marrow suppression surveillance. This case gives an example and best practices for management. An infant was delivered vaginally and there were maternal vaginal vesicles noted at the time of delivery. You should determine the maternal serostatus and give acyclovir to the baby while waiting for the result. If the mother has primary or first-time disease with active lesions, the infant needs an LP and blood work for HSV PCR, as well as a course of 10 days of acyclovir. If the mother has a known HSV recurrence, you can just monitor the baby for 48 hours without an LP, and you can also defer the acyclovir and discharge if the blood work is negative. 75% of infants with HSV are born to women with no history of HSV. A few of the congenital infections were associated with the blueberry muffin rash. Essentially, this is a symptom of extramedullary hematopoiesis occurring. It's also seen with hereditary spherocytosis, hematologic disease of the newborn, twin-to-twin transfusion, hemangiomas, neuroblastoma, rhabdomyosarcoma, Langerhans cell histiocytosis, and congenital leukemia cutis. If suspicious about a congenital infection, patients often need screening ophthalmologic exams, hearing tests, a head ultrasound for hydrocephalus evaluation, head CT for calcification evaluation, and serologies for toxo, RPR, rubella, and parvo. It can also be prudent to document that the maternal antibody for syphilis, toxo, or rubella is declining. Congenital HIV presents with failure to thrive, developmental delay, recurrent infections, thrush, and infection with RSV and PCP pneumonia. Risk factors for congenital HIV are high maternal viral load or advanced disease, birth trauma, vaginal delivery without suppressed viral load, primary maternal disease during pregnancy, and concurrent infections. Pregnant women with HIV should take zidovudine or nevirapine. Infants of infected mothers should receive zidovudine within 72 hours of birth and take this for up to 6 weeks if the maternal viral load is undetectable. If the maternal viral load is detectable, combination antiretroviral therapy should be given. This is tenofovir and entricitabine, and dolutegravir or raltegravir. Combination antiretroviral therapy is also used for HIV needle stick exposure treatment. HIV medications can cause pancreatitis, Stevens-Johnson syndrome, pneumonitis, neuropathy, neutropenia, and liver and renal disease. Infants with HIV-positive mothers also need Bactrim for PCP prophylaxis for 6 weeks. The AAP updated its recommendations to allow breastfeeding with HIV if on treatment and demonstrating viral suppression. HIV is diagnosed with HIV antibody testing, HIV DNA PCR at birth, 2 to 6 weeks, and at 4 months. So you need 2 additional negative PCR tests from the tests at birth to confirm that the HIV negative status is remaining. Zika virus is transmitted by the Aedes mosquito and causes fever, rash, arthralgias, myalgias, headaches, and Guillain-Barré syndrome. Congenital transmission causes microcephaly and SGA, ocular abnormalities, and sensorineural hearing loss. Zika virus is diagnosed with PCR. Many of the symptoms for congenital infections overlap, but here are some unique symptoms for specific pathogens. Nephrotic syndrome and edema is associated with syphilis. Chorioretinitis is associated with toxoplasmosis and CMV. Periventricular calcifications are associated with CMV, and diffuse parenchymal calcifications are associated with toxoplasmosis. Failure to thrive is most associated with HIV. Congenital heart defects are most associated with rubella. Neonatal sepsis or meningitis are most associated with HSV. Hydrops fetalis is associated with parvo and syphilis, and microcephaly is associated most with Zika virus. The workup for a febrile neonate is algorithmic, with the goal of optimizing workup and treatment based on the likelihood of serious bacterial infections. Neonatal sepsis is most commonly from GBS and E. coli. HSV should be considered, though, if CSF shows pleocytosis or if seizures occur. Strep is the most common neonatal bacteremia. In immunocompromised patients, it's more common to see Klebsiella and Pseudomonas, though. For febrile neonates in the first week of life, they receive a full workup and AmpGent rule out, with vancomycin added if there's a concern for meningitis or MRSA. Urine studies are not needed in the first week of life because if these are positive, then bacteremia is presumed in this young population. Between 1 and 3 weeks, the workup is still comprehensive and still includes an LP up to 3 weeks old, but at this time period, you should also check the urine studies. Between 3 weeks to 2 months, an LP is only needed if the neonate looks very sick or has high inflammatory markers. And then between 2 and 3 months, you only need a urine study as a requirement. An infant is born at 36 weeks by C-section to a 20-year-old G0P0. Pregnancy is complicated by oligohydramnios, decreased fetal movements, and slow growth toward the end of gestation. Birth weight is 1.95 kilograms. Hepatosplenomegaly and diffuse petechiae are present. The AST is 540, the ALT is 650, and the platelets are 56,000. CT shows periventricular calcifications. Therapeutic management should include acyclovir IV, pyrimethine with sulfadiazine and folic acid, crystalline penicillin G, ganciclovir IV, or vancomycin. The correct answer is ganciclovir. You're attending a C-section for a term newborn. The OB tells you that the C-section is indicated due to visible HSV on her labia. The mother confirms a history of genital HSV. The infant is admitted to the nursery for observation. What is the next best step in the management of the infant? Administration of immune globulin for post-exposure prophylaxis, viral surface cultures and observation without antiviral medication, acyclovir IV for 72 hours and discharge home if the infant remains well, obtain viral surface cultures and initiate oral acyclovir for a 14-day course, or obtain viral surface cultures and initiate IV acyclovir for a 14-day course. The correct answer is to obtain viral surface cultures and observe the patient without antiviral medication. Now we'll move on to viral diseases. Varicella can be transmitted directly with contact or airborne. Chickenpox describes the first infection with varicella, and it becomes shingles when reactivated. There's up to 3 weeks of incubation, followed by a mild prodrome before the rash. Patients are contagious for 2 days before the rash starts. The rash is generalized, vesicular, and pruritic. Usually starts on the head and then moves down the trunk. It lasts for about 7 to 10 days, and lesions can have different stages of healing or crops during this time. Congenital varicella infection occurs with maternal infection in the first or second trimester. Babies can have hypopigmented cutaneous scars called cicatrix, limb hypoplasia, clubfoot, rudimentary digits, encephalitis, hydrocephalus, chorioretinitis and cataracts, microphthalmia, and paralysis. Varizig is indicated if the mother had symptoms 5 days before or 2 days after delivery. Varizig can also be beneficial for exposed premature infants with non-immune mothers, immunocompromised infants, and susceptible pregnant women. Varicella infection is treated with acyclovir within 24 hours of the rash. If a patient is immunocompromised, this medication should be IV. Complications of varicella infection include pneumonia, encephalitis, Ray's syndrome, hemorrhagic varicella, and hepatitis in immunocompromised hosts. Epstein-Barr virus is usually asymptomatic in infants and in young children, but older children will have fatigue, fever, sore throat, lymphadenopathy, splenic enlargement, rash, and edematous upper eyelids. The lymphocytes are atypical, and heterophile antibodies can be diagnostic for up to 6 months. This test is less sensitive in children younger than 4 years. Acute infection is also diagnosed with a VCA IgM or the early antigen or EA. Anti-EBNA antibodies develop last. You can think of EBNA with non-active, and this would not be suggestive of acute EBV. EBV can progress to splenic rupture, myocarditis, orchitis, granulocytopenia, thrombocytopenia, hematophagic lymphohistiocytosis, and EBV would be fatal in patients with Duncan syndrome. Duncan syndrome is an X-linked disease that causes lymphoproliferation. EBV is treated with steroids if there's airway concerns and at least 3 weeks of rest to avoid splenic trauma, but mostly supportive care. HSV6 or roseola is a DNA virus. Babies are most commonly infected with it at 6 to 12 months after the maternal antibodies have waned. It presents with a sudden high fever and febrile seizures, followed by a rash when the fever subsides. Immunocompromised patients can develop meningitis, encephalitis, and pneumonia from roseola. Measles is an RNA virus spread through airborne or direct contact. Patients are contagious from 4 days before to 4 days after the rash, which is a macular rash that spreads down from the face. Patients can also have cough, coryza, conjunctivitis, and Koplik spots inside the mouth. The most common cause of death from measles is bronchopneumonia. Patients can also have croup, encephalitis, acute otitis media, and they can develop subacute sclerosing panencephalitis or SSPE, which is a long-term complication of measles where CNS degeneration presents with seizures 7 to 10 years after the initial infection. Patients with measles should be isolated with standard and airborne precautions. As a reminder, measles, TB, varicella, and aspergillus need airborne precautions. Infants and immunocompromised patients should be treated with immune globulin within 1 week of exposure. For older and immune-competent patients, the MMR vaccine can be used if within 3 days of exposure, and IVIG can be used if exposure occurred between 4 and 6 days ago. Post-exposure prophylaxis with the MMR vaccine is indicated if the first MMR was never received or if it was at least 28 days since the first MMR. Fully vaccinated patients with 2 MMR vaccines do not need post-exposure prophylaxis. Pregnant women should receive IVIG within 6 days of exposure if they're non-immune on their measles titer. Parvovirus with a rash called erythema infectiosum presents with malaise, headache, fever, and large joint arthralgias. The rash is described as a slapped cheek rash with perioral sparing and a lacy rash on the torso. Patients with spherocytosis, sickle cell disease, and thalassemias can have a transient aplastic crisis. Congenital parvo infection before 20 weeks gestation can result in anemia, cardiac failure, and hydrops fetalis. This is diagnosed with a maternal IgG or PCR from the amniotic fluid. Effects may be mitigated with red blood cell transfusions in utero. Coxsackie virus can cause hand-foot-mouth disease, herpangina, high fever with oral lesions. Enterovirus causes high fever, rash, and aseptic meningitis. Enterovirus is more common in the summer, as well as adenovirus, which can present with a pharyngitis that mimics strep pharyngitis. Arbovirus, transmitted by mosquitoes, can cause encephalitis and requires acute and convalescent antibody titers to diagnose. For RSV, a chest X-ray may depict hyperinflation and diffuse infiltrates. RSV is the most common cause of bronchiolitis, followed by rhinovirus, then influenza. We describe severe bronchiolitis if the PO2 is less than 65, PCO2 is greater than 40, respiratory rate is greater than 70, or the oxygen saturation is less than 90. SARS, or non-COVID coronavirus, causes respiratory symptoms and does not have effective treatments. SARS typically has a febrile prodrome for up to 1 week without URI symptoms. This slide comprehensively reviews antibiotic considerations in children. Doxycycline is approved for children younger than 8 years old in short courses, and tetracycline can be given for children older than 8 years. Short courses would mean less than 3 weeks. Fluoroquinolones can cause tendon rupture in children, but may be needed for complicated UTI or pyelonephritis or for chlamydia pneumonia. Ciprofloxacin, a fluoroquinolone, is also first line when needing to treat Shigella infections. For the macrolides, azithromycin is favored for infants younger than 6 weeks old because erythromycin has a higher risk for pyloric stenosis. When someone has a penicillin allergy, the risk for concurrent cephalosporin allergy is possible, but less than 10%. Clindamycin is useful for gram-negative bacteria and has MRSA coverage, but is not effective against Enterococcus. Enterococcus also resists cephalosporins, so you should treat Enterococcus with vancomycin, linezolid, or ampicillin. Metronidazole is used to treat Giardia, Entamoeba histolytica, Trichomonas, Bacteroides, Clostridium, and Gardnerella. The first generation cephalosporins are Keflex and cefazolin or Ancef, and they mostly cover gram-positive bacteria. Cefaclor, cefoxitin, and cefuroxime are the second generation cephalosporins and give better gram-negative coverage. The second generation ones are useful for treating H. flu, Enterobacter, and Neisseria. Carbapenems and imipenem also treat Enterobacter, which is a common culprit for ESBLs. The third generation cephalosporins are ceftriaxone, ceftazidime, and cefotaxime. Ceftriaxone and vancomycin is a common combination regimen for meningitis. Ceftazidime has pseudomonal coverage, which is also important to remember. Finally, cefepime is the fourth generation medication and has good CNS penetration and broad coverage. Now we'll discuss nuances for different bacterial infections, starting with gram-positive pathogens. Enterococcus faecalis is a gram-positive diplococcus. It causes necrotizing enterocolitis and UTI. You have to treat Enterococcus with vancomycin, linezolid, or ampicillin. It is not covered by cephalosporins. Listeria is a gram-positive rod, and you may hear the buzzword nodules on the placenta for listeria. This is treated with ampicillin. Clostridium is gram-positive as well. Clostridium botulinum or botulism has a toxin that inhibits acetylcholine release and causes a progressive and descending weakness, ptosis, poor suck, and urinary retention and constipation. Clostridium tetani or tetanus infection causes lockjaw and muscle spasms. Botulism needs the antitoxin, but tetanus can be treated with penicillin or metronidazole and tetanus immunoglobulin. As a reminder, the condition of cyclic neutropenia is associated with susceptibility to Clostridium infections. Corynebacterium diphtheria is a gram-positive rod. Infection with diphtheria can cause a pseudomembrane on the tonsils and pharynx, motor and sensory problems, and hyporeflexia. The Loeffler or Tinsdale augers are used to diagnose diphtheria. Diphtheria is treated with penicillin or erythromycin. Staph aureus looks like gram-positive clusters. If Staph aureus bacteremia is diagnosed, patients need an echo to rule out vegetations and prolonged IV antibiotics. Staph aureus can also cause bullous impetigo, follicular infections, and abscesses. Sometimes these need incision and drainage only, but Bactrim or clindamycin may be indicated if the skin infection is greater than 5 centimeters, And Staph aureus patients can progress to toxic shock syndrome, where patients have watery diarrhea and emesis and present like sepsis. With cons and staph epidermidis, the most common skin flora, patients need vancomycin until the culture specificities confirm that the pathogen is not actually MRSA. MRSA is also highly suspected before culture results for infections of VP shunts and for bacterial peritonitis, so a vancomycin rule-out period is appropriate. Streptococcus looks like gram-positive cocci in pairs and chains. Strep viridans and strep pneumo are the alpha hemolytic subgroup. Strep pneumo is the most common cause of pneumonia overall, but in cystic fibrosis patients, it's Staph aureus or Pseudomonas. Strep pneumo is also the most common cause of incidentally noted bacteremia, which does not require treatment if asymptomatic. Strep viridans is the most common cause of endocarditis. Group B strep, GBS, also called strep agalactiae, and then group A strep or strep pyogenes make up the beta hemolytic strep species. Group A strep causes strep pharyngitis, which can progress to PSGN and rheumatic fever. Penicillin treatment can prevent rheumatic fever but not post-strep glomerulonephritis. PSGN can present with hematuria, proteinuria, hypertension, edema, and a low C3, and is treated with fluids, diuretics, and sometimes steroids or cyclophosphamide. These patients are monitored until their C3 normalizes. If it takes longer than 6 weeks, then you'd consider another diagnosis like lupus or membranoproliferative glomerulonephritis. Strep pharyngitis can progress to peritonsillar abscesses where patients show a deviated uvula, or retropharyngeal abscesses where patients prefer neck hyperextension. Retropharyngeal abscesses can also be seen on lateral neck x-ray. These abscesses should be treated with Unison and clindamycin IV and then transition to oral augmentin after abscess drainage. The rash that's associated with strep pharyngitis is sometimes called scarlet fever and can look like a sandpaper rash, notably in the creases or Pastia's lines, perioral pallor, and strawberry or white tongue. Group A strep can also progress to strep toxic shock syndrome and necrotizing fasciitis. Early onset GBS in the first week of life can cause pneumonia, and later onset GBS usually causes more focal infections like meningitis. GBS is treated with penicillin. Let's review intrapartum GBS infections in more detail. Mothers are screened at 36 weeks. Antibiotic prophylaxis is indicated if there's a positive screen, if there is invasive disease in a previous pregnancy, or if the GBS status is unknown and the baby is gestational age less than 38 weeks, rupture membrane is 18 or more hours, or there was maternal fever. The treatment, if indicated, is IV penicillin, ampicillin, or cefazolin at least 4 hours prior to delivery. If a newborn still develops GBS disease, this is treated with ampicillin and gentamicin or vancomycin and gentamicin. You would use nafcillin instead of ampicillin for bone and soft tissue infections, and add cefotaxime if you're treating GBS meningitis. Now the gram-negatives, which notably frequently end in the suffix "ella". Bartonella presents with draining and tender lymphadenopathy and is self-limited unless a patient is immune-compromised or develops hepatosplenomegaly. Bartonella is treated with macrolides, cephalosporins, doxycycline, or Bactrim. Bordetella pertussis is associated with lymphocytosis and it's diagnosed with PCR. Pertussis is treated with macrolides, and all contacts need prophylaxis regardless of vaccine status because immunity wanes over time. Macrolides for pertussis can also shorten the infectious catarrhal stage. Rickettsia, or Rocky Mountain spotted fever, presents with thrombocytopenia, petechiae, headaches, and a rash at the palms and soles that spreads to the trunk. The diagnosis of Rocky Mountain spotted fever can be confirmed with a lesion biopsy, and Rocky Mountain spotted fever is treated with doxycycline. Ehrlichia is a similar pathogen, but it can also cause liver dysfunction and leukopenia and lymphopenia. Ehrlichia is also treated with doxycycline. As discussed previously, Enterobacter is a gram-negative bacteria responsible for UTI and respiratory infections and requires a cephalosporin or a carbapenem like imipenem for ESBL infection treatment. Citrobacter should be considered if a patient has brain abscesses. Chlamydia can cause LGV, which presents with small, non-tender papules or ulcers, followed by tender unilateral inguinal lymph nodes. Chlamydia STDs are treated with doxycycline for 1 week, or alternatively, a single dose of azithromycin or a week course of levofloxacin if you're unable to give doxycycline. Chlamydia conjunctivitis is treated with oral erythromycin. Chlamydia pneumonia can have a cough that's described as staccato, and it's treated with erythromycin or azithromycin. You might consider azithromycin if your patient is younger than 6 weeks old. Mycoplasma pneumonia causes an atypical pneumonia and bullous meningitis. You need PCR or IgM to diagnose mycoplasma pneumonia, and it's treated with macrolides. Chlamydia psittaci also causes an atypical pneumonia and is treated with doxycycline or macrolides. H. flu should be considered more in patients without immunizations, immigrant patients, and in asplenic patients who are susceptible to encapsulated organisms. H. flu is described as a pleomorphic organism and is treated with ceftriaxone. Finally, Pseudomonas is worse for patients with cystic fibrosis, and it's treated with ceftazidime, cefepime, ticarcillin, carbonicillin, piperacillin, gentamicin, tobramycin, ciprofloxacin, or levofloxacin. So for Pseudomonas, you think about the higher generation cephalosporins, aminoglycosides, and fluoroquinolones. The encapsulated bacteria are Strep pneumo, Neisseria meningitis, Klebsiella pneumonia, H. flu, Salmonella typhi, Cryptococcus, and Pseudomonas. Patients are typically vulnerable when they've had a splenectomy, sickle cell disease, and if they have X-linked Bruton agammaglobulinemia. With tuberculosis infections, patients may present with supraclavicular lymph nodes or URI symptoms most commonly. When interpreting a PPD, the tiers of positivity are 5, 10, and 15 millimeters. Let's call them low, medium, and high. If the induration is less than 5 millimeters or low, it's negative. If it's between 5 and 10 millimeters, medium-low, it's considered positive for high-risk patients. So this medium-low tier, 5 to 10, is positive for patients who've had an exposure history, chest x-ray findings, or who are immune compromised. If the induration is between 10 and 14, medium-high, it's considered positive if there are any risk factors. An induration of 15 millimeters or more, that's a high level of induration, is always positive, no matter what the history or exam findings are telling you. Of note, the BCG vaccine can cause a false positive PPD. Treatment for TB depends on if you're considering it to be latent without chest x-ray findings or active with chest x-ray findings. Latent TB is treated with isoniazid for 9 months, and active TB is treated with 3 to 4 drug therapy. For mothers found to be PPD positive, the newborn should be started on isoniazid for a year with the PPD monitored every 3 months, and then you should initiate that 3 to 4 drug therapy if the PPD ever becomes positive. If the mother demonstrates active disease and not just a positive PPD, you should treat the infant with 3 to 4 drug therapy as if they have a positive PPD as well. If someone is exposed to a PPD positive household contact, they should take isoniazid for 3 months if their PPD is negative and for 9 months if it's PPD positive. If you're exposed to someone with TB in your household and you have chest x-ray findings, then you initiate 3 to 4 drug therapy as if you're treating an active TB. TB meningitis may need steroids and streptomycin added to the regimen. The spirochetes include Borrelia burgdorferi or Lyme disease, syphilis, and leptospirosis. Lyme is diagnosed with antibody titers and confirmed with a Western blot. The Jarris-Herxheimer reaction of fever, chills, hypotension, headache, myalgia, and worsening skin lesions can occur with antibiotic treatment of Lyme and syphilis. Leptospirosis is transmitted in animal urine and causes a conjunctivitis that doesn't have a discharge, a transient rash, abdominal pain, and headache and meningitis. Blood cultures can diagnose leptospirosis in the first week, and it's treated with penicillin, similar to syphilis. Fungal infections are treated with itraconazole, fluconazole, or ketoconazole, depending on the pathogen, if stable. If the patient is unstable, we use amphotericin B, and we use liposomal amphotericin B for patients with renal disease. Cryptococcus can cause pneumonia or meningitis, and it's diagnosed with a stain called India ink. You treat cryptococcus with fluconazole or amphotericin depending on the severity, and if they have just isolated pneumonia, you can just use fluconazole. Blastomycosis is described as a broad budding yeast, and it's commonly associated with Chicago. Blastomycosis is treated with itraconazole. Coccidiomycosis is found in Texas, Arizona, and California and causes pneumonia. Cocci is treated with amphotericin or fluconazole or ketoconazole. Histoplasmosis is found in Ohio and Mississippi and causes pulmonary fibrosis, hepatosplenomegaly, and shows mediastinal or hilar calcifications on chest X-ray. Histo is also treated with fluconazole or ketoconazole or amphotericin. Finally, aspergillus causes a hypersensitivity reaction called ABPA in immunocompetent patients, but has a worse outcome for patients with cystic fibrosis and asthma. It causes eosinophilic nodular lung infiltrates and invasive disease. Aspergillus is treated with itraconazole and steroids usually, but if it's severe or invasive, then you think about voriconazole or isofluvoconazole. Aspergillus is a common culture contaminant, so you shouldn't treat patients with antifungals for a positive culture unless they're also symptomatic and you're sure this is what you're treating. Next, we'll discuss parasites and protozoa. Entamoeba histolytica, found in the southwestern United States, causes a GI illness with abdominal pain, diarrhea, and tenesmus. It's diagnosed with stool PCR, and you use an ultrasound to evaluate for liver abscesses. Entamoeba histolytica is treated with metronidazole or iodoquinol. Trichomonas is an STD that causes a yellow-green frothy discharge and has motile flagella and a high pH greater than 4.5 on microscopic exam. It's associated with the strawberry cervix. Trichomonas is treated with metronidazole. Babesia is transmitted via the Ixodes tick and causes mild fevers and hemolytic anemia. On a smear, Babesia has the Maltese cross, and you treat it with quinine and clindamycin. Cryptosporidium causes a chronic watery diarrhea for weeks, and it's diagnosed with PCR, DFA testing, or the presence of stool cysts. Cryptosporidium is usually treated with supportive care, but immunocompromised patients or severe cases may need nitazoxanide. When patients contract malaria, they have cycles of cold, rigors, and high fevers, hepatosplenomegaly, and hemolytic anemia. A blood smear will speciate the specific malaria type. Vivax and Ovale are associated with relapsing disease because of their ability to remain dormant in the liver, but Malaria falciparum and Malariae species do not relapse. Trypanosoma cruzi, also called the Chagas disease, is transmitted by the reduvide bug in South America and causes heart failure or heart block and hypercoagulability with clot formation. Finally, Trypanosoma brucei, also called African sleeping sickness, is transmitted by the tsetse fly and causes a disease progression with insomnia, fever, tremors, irritability, and then a coma. Worm infections are usually treated with albendazole, pyrantel pamoate, or praziquantel, depending on the specific type. A common theme for treatment is that the doses are repeated again after 2 weeks to ensure eradication of the worms that are delayed in their life cycle. Enterobius, or pinworms, are diagnosed using the tape test and treated with albendazole. Ascaris lumbricoides, found in tropical environments, can cause pancreatitis, bowel obstruction, and bronchitis with shifting infiltrates on chest X-ray. The pulmonary eosinophilia with shifting infiltrates is also called Loeffler syndrome. Ascaris lumbricoides is diagnosed with stool studies and treated with albendazole or pyrantyl pamoate. Schistosomiasis or flatworms cause chronic intermittent abdominal pain, bloody stool, and hepatosplenomegaly. Schistosomiasis is treated with praziquantel. Tinea solium or pork tapeworm causes neurocysts and seizures and needs albendazole or praziquantel. Tinea saginata or beef tapeworm causes GI symptoms and is treated with praziquantel. Toxocara canis or visceral larva migrans involves many systems, including the lungs, GI tract, and the eyes. Patients with Toxocara canis may have hepatosplenomegaly and wheezing. It's treated with albendazole. Hookworms cause foot itching, then cough and wheeze and GI symptoms, and you can get anemia and malnutrition from the GI involvement. Hookworms are treated with albendazole and iron supplementation. If just localized to the skin, it's called cutaneous larva migrans. This rash is itchy and serpiginous and is treated with albendazole or ivermectin. Trichuris or whipworm causes diarrhea and rectal prolapse and is treated with albendazole. Filariasis or tropical roundworms cause orchitis, epididymitis, inguinal adenopathy, and elephantiasis if the lymphatic system is affected. Filariasis is treated with doxycycline or diethylcarbamazepine, and these are atypical treatments for worm infections. Finally, Diphyllobothrium laudum or fish tapeworm can cause B12 deficiency most notably and is treated with praziquantel. This slide reviews specific disease processes and some high-yield buzzwords for the test. If you hear about ground glass pneumonia, think about PCP or GBS infections, or RDS and surfactant deficiency. If you hear about underinflated lungs with air bronchograms, this may be more suggestive of GBS or surfactant deficiency. And in an adolescent with pneumonia, think about mycoplasma. You diagnose this with PCR or IgM, and with chlamydia, diagnosed with PCR. These would be treated with a macrolide or doxycycline. In a patient with spontaneous bacterial peritonitis, E. coli is a common pathogen, and it's reasonable to treat with cefotaxime until the cultures result. In cases of secondary peritonitis from dialysis, think about staph epidermidis as a skin flora and treat empirically with vancomycin from MRSA. If someone has swelling below their jaw or unilateral periorbital swelling suggestive of infection, remember that dental abscesses can swell in these locations. Sinusitis is most commonly caused by H. flu, Moraxella, and strep pneumo. Mastoiditis is diagnosed with tympanocytis with a culture of the fluid and a CT. For lymphadenopathy evaluation, the differential can be algorithmic. Acute lymphadenopathy is present for less than 3 weeks. If acute lymphadenopathy is submandibular or cervical, consider strep pyogenes. If it's preauricular, consider mono or adenovirus. Chronic lymphadenopathy is present for more than 3 weeks. Bartonella has draining and tender lymphadenopathy. You treat patients who are immune compromised or have hepatosplenomegaly with macrolides, cephalosporin, doxycycline, or Bactrim. Francisella tularemia is a glandular disease with pleomorphic gram-negative bacteria transmitted by ticks on deer or rabbits. Patients can have fever, hepatosplenomegaly, lymphadenopathy, and ulcers. Mild to moderate Francisella is treated with gentamicin or ciprofloxacin, and severe disease is treated with gentamicin or streptomycin. Brucella is treated with doxycycline and rifampin. If a patient's younger than 8 years old, then you would think about Bactrim instead of doxycycline. Brucella spondylitis or endocarditis needs an aminoglycoside additionally, and if you have central nervous system brucellosis, then you need the blood-brain barrier penetration by ceftriaxone. Atypical mycobacteria lymphadenopathy is treated with surgical incision, but lymphadenopathy from tuberculosis itself is not excised unless it becomes a draining abscess. The treatments for tuberculosis were discussed previously. Lymphadenopathy from LGV chlamydia is treated with doxycycline or erythromycin. Yersinia is treated with streptomycin after your lymph node aspiration confirms the diagnosis. Sporotrichosis or rose picker's disease presents with a single painless nodule that ulcerates. It's treated with itraconazole, amphotericin B, terbinafine, fluconazole, or potassium iodide, depending on the illness severity. Knowing the CSF cell counts to determine if it's viral or bacterial meningitis is also important. With bacterial meningitis, you'll see a high protein count and low glucose, but with viral disease, you'll see normal or high protein and normal glucose. With bacterial meningitis, you'll see a neutrophilic predominance to contrast with the lymphocytic predominance of viral meningitis. And then with bacterial meningitis, your leukocyte count will be greater than 100, and with viral, it should be less than 500. Bacterial meningitis is treated with AMP-Gent for listeria in infants who are less than 30 days old, and then we commonly use the regimen of vancomycin and ceftriaxone for older patients. If you have a traumatic LP with red blood cells in the sample, you can consider that for every 1,000 red blood cells, you just have one white blood cell. This slide reviews some of the nuanced media and agar types for different infections. For pertussis, you might see the buzzwords about Reagan-Low or Borde-Gingo media. For diphtheria, they use Loeffler or Tinsdale agar. For Neisseria gonorrhea, they use Thayer-Martin agar. For Cryptococcus, they use India ink staining. For the encapsulated organisms, GBS, H. flu, Neisseria, meningitis, and strep pneumo, they use latex agglutination. And then if you're given the choice between antibody studies like DFA or ELISA versus PCR, use the antibody studies because they're more accurate than PCR. A 10-month-old boy has a cough, conjunctivitis, and coryza. He has a fever and a macular rash on his head, trunk, and proximal extremities. The complication most responsible for mortality with this illness is encephalitis, hemorrhagic shock, hepatitis, myocarditis, or pneumonia. The correct answer is measles pneumonia. A 15-year-old girl has 5 days of fever, fatigue, and sore throat. She has enlarged cervical lymph nodes and a mildly enlarged liver and spleen. Rapid strep is negative. Her titers are as follows: monospot positive, VCA IgM negative, VCA IgG positive, and EBNA positive. Which of the following is a correct interpretation of her EBV serologies? Acute EBV infection, past EBV infection, chronic active EBV infection, unable to determine EBV timing, or she has Lyme disease. The correct answer is past EBV infection. A 28-year-old woman is 10 weeks pregnant and her 2-year-old unvaccinated son was diagnosed with varicella. The woman has no history of varicella and hasn't received the vaccine. If she develops primary varicella, the best description of the outcome of the fetus is cardiac anomalies, diarrhea, and hepatosplenomegaly, chorioretinitis, thrombocytopenia, and hepatosplenomegaly, endocarditis and endocardial fibromatosis, eye and brain abnormalities, scarring of the skin and limb hypoplasia, or skin involvement alone with vesicles persisting for 1 month after delivery. The correct answer is eye and brain abnormalities, scarring of the skin, and limb hypoplasia. Now we'll move on and discuss pathogens that cause acute infectious diarrhea in more detail. The most common pathogens that cause acute infectious gastroenteritis are norovirus, salmonella, rotavirus, shigella, parasites like giardia and cryptosporidium, campylobacter, E. coli, and food poisoning. Watery diarrhea is more likely to represent an infection in the small bowel. You're more likely to see vomiting and less likely to have a fever. With your stool sample, you're more likely to have a low number of stool white blood cells, and you're more likely to have a normal CBC. With dysentery or infection in the colon, you're more likely to have bloody and small volume diarrhea, more likely to have a fever and not have emesis. And on your stool sample, you're more likely to have higher numbers of white cells and more likely to have leukocytosis on your CBC. We'll start with the culprits for watery diarrhea. Rotavirus is seen most commonly in children younger than 2 years old. We commonly see outbreaks in daycares. Rotavirus also can cause vomiting in addition to watery diarrhea. Norovirus is the most common cause of gastroenteritis. It has a shorter illness period than most other gastros, 1 to 3 days. We see this in association with epidemics on cruises, in schools and restaurants. Some food culprits are shellfish and salads. If a season is given in a vignette on a question, norovirus can be associated as the winter vomiting disease. Giardia is more commonly seen in the summer as a parasite in water. We also see this when patients have been traveling and when they're in daycares, and sometimes the stools for Giardia are described as foul-smelling. Cryptosporidium is also seen in water, so associated with swimming, farm animals, and daycare. The illness period is up to 3 weeks and is associated with weight loss and with chronic diarrhea if a patient is immunocompromised. There's quite a few more pathogens that cause dysentery or infection in the colon. We'll start with Shigella. This is most commonly seen in patients 1 to 5-year-old. They have watery diarrhea. Shigella toxin can cause seizures, which is an important buzzword. And we see Shigella in patients who've traveled or go to daycare. Salmonella typhi causes typhoid fever. We might see rose spots and hepatosplenomegaly for Salmonella. Non-typhoid Salmonella can cause bacteremia, osteomyelitis, and meningitis. Most importantly, it can also cause abscesses. We see this in patients who've been exposed to improperly cooked eggs, milk, raw produce, and we see non-typhoid Salmonella when a child has a pet reptile. Non-typhoid Salmonella is higher risk for infants, for patients with sickle cell disease, patients with asplenia, and patients with HIV. Campylobacter is associated with poultry, milk, farm animals, and daycare. Patients will report cramping with Campylobacter, and it's associated with progression to Guillain-Barré. Yersinia is associated with pork, farm animals, and it's seen in older children. It can cause mesenteric adenitis, pseudoappendicitis, arthritis. It can also cause meningitis and osteomyelitis. Shiga toxin producing E. coli is seen in ground beef, raw produce, farm animals, patients who've been swimming. It can cause bloody diarrhea, and an important connection to Shiga toxin E. coli is hemolytic uremic syndrome, or HUS. This triad involves microangiopathic hemolytic anemia, thrombocytopenia, and acute renal dysfunction. C. diff is associated with previous use of clindamycin, ceftriaxone, penicillin, or quinolones. It can cause pseudomembranous colitis, bloody diarrhea, cramping, and fevers. Patients who are 1 to 3-year-old can have asymptomatic carriage of the C. diff bacteria. Entamoeba histolytica causes cramps, tenesmus. It can kind of look like IBD, especially because it has a gradual onset, and it can also cause liver and brain abscesses. We covered most of these buzzwords when we were talking about the pathogens specifically, but this slide series just gives some specific buzzwords. Daycare was associated with quite a few pathogens. These include rotavirus, Giardia, Cryptosporidium, Shigella, Campylobacter, and Shiga toxin producing E. coli. Different types of food. So norovirus is associated with shellfish and salads. Salmonella is associated with milk and produce. Shiga toxin producing E. coli is associated with produce, and Campylobacter is associated with dairy. Outdoors, we're more likely to see Giardia, which causes more prolonged symptoms, and flatulence. Cryptosporidium also can cause prolonged symptoms. And then we'll see Shiga toxin producing E. coli outdoors as well. In the fall and winter, we'll see rotavirus and norovirus. And in the summer, we're more likely to see Giardia, Cryptosporidium, and Shiga toxin producing E. coli. For most acute infectious gastroenteritis, you can just treat with supportive care. If a patient has a fever, if they're immune compromised, if there's bloody stool or a prolonged course, you might consider checking a stool OMP, getting a culture, and or checking serologies, especially for the white count and the liver function tests. If you identify or you're suspicious about E. coli, you can treat with azithromycin, ceftriaxone, rifaximin, or ciprofloxacin. For Giardia, you can treat with Flagyl, nitazoxanide, or tinidazole. Cryptosporidium, you can also treat with nitazoxanide. For non-typhoid salmonella, if you treat it, it can actually prolong the carriage. So you would consider really severe colitis if a patient's an infant less than 3 months old, if they have a hemoglobinopathy, if they're immune compromised, just treatment for those situations. You would treat with ceftriaxone, azithromycin, or quinolones for non-typhoid salmonella. For Campylobacter, you can use azithromycin. For Yersinia, you can use Bactrim, aminoglycosides, or fluoroquinolones, but you would consider just treating if the disease seems invasive or if they're immune compromised for Yersinia. With Shiga toxin producing E. coli, antibiotics can actually increase the risk for HUS, so you would hold off unless you really need to treat it. For C. diff, you would most commonly use vancomycin. Flagyl is second line after vancomycin. Finally, for Entamoeba histolytica, you would use Flagyl, tinidazole. You can also use iodoquinol to clear the intestinal cysts if those are present and found on an ultrasound. So overall, treatment is more nuanced for non-typhoid salmonella, for Yersinia, and for Shiga toxin producing E. coli. What is the most likely food or water associated agent with persistent diarrhea greater than 14 days? Campylobacter, Giardia, norovirus, rotavirus, or Shigella? The correct answer is Giardia. If Cryptosporidium was on this list, it would be a tough decision between Giardia and Cryptosporidium. Cryptosporidium was associated with more advanced disease in patients with immune compromise. An 18-month-old girl has 1 day of mucousy diarrhea and fever before a seizure. She goes to daycare and other children have GI illnesses. She recently finished amoxicillin for acute otitis media. She lives on a farm. The most likely cause of her illness is Campylobacter, C. diff, Cryptosporidium, Salmonella, or Shigella. The correct answer is Shigella. Finally, why might antibiotics use in children with E. coli infection be contraindicated? Antibiotics increase stress on the kidneys. Antibiotics increase the risk for hemolytic uremic syndrome. E. coli is resistant and not treatable. Fecal carriage increases with antibiotic use. The correct answer is that antibiotics increase your risk for HUS. That is the last question for this slide series.